Welcome to the deep dive. Today we're really getting into a big one, stroke, using the revision notes you shared, aimed squarely at the MSRA exam.
That's right. And our plan for this deep dive, cut right through all the detail, pull out the absolute must-know, high-yield stuff from these specific notes, and make it stick for you.
Exactly. Think of this as us walking you through the core facts, pointing out what really matters for the exam, and honestly for practice too.
Okay, let's dive right in.
Right. Starting at the top, definition and classification. The notes kick off calling stroke, or CVA, a medical emergency. What's the immediate thing we need to get?
The absolute core idea is sudden disruption. Blood supply to the brain just stops or gets severely interrupted.
Sudden disruption. Okay.
And because brain cells start dying within minutes without oxygen, the critical message is speed, immediate action. Time is brain, truly.
Got it. And the notes classify it based on, well, how that disruption happens.
Yep, two main types. You've got ischemic, that's the big one. Around 80%, according to your notes, that's a blockage.
80% blockage.
And then hemorrhagic, about 15%, where a blood vessel actually bursts, a bleed.
That 80-15 split feels like a classic exam number to have locked down.
Definitely. And tucked under ischemic, your notes mention TIA's transient ischemic attacks. These are really important.
The mini stroke.
Yeah, that's what the notes call them. Basically stroke symptoms, but they completely go away within 24 hours. But, and this is crucial, they're a massive red flag for a future, potentially much bigger, stroke.
Okay, so TIA, ischemic, temporary, but a serious warning. Now, the notes bring up the Oxford or Bamford classification based on symptoms. This feels like prime exam territory.
Oh, it absolutely is. It's a way to quickly group strokes based on what you're seeing clinically. It gives you clues about which part of the brain, which vessels are involved.
And it hinges on key signs like weakness, sensory loss, vision problems, speech issues.
Exactly. Specifically, unilateral weakness or sensory loss, face, arm, leg. Homonymous hemianopia, that visual field defect. And higher cortical stuff like dysphagia, the language problems.
Okay, let's quickly hit the types from your notes. TACI, total anterior circulation infarct.
Right. TACI means major anterior vessels are involved. You see all three of those key signs. The weakness, sensory loss, the hemianopia, and the higher cortical dysfunction. Big stroke, big deficit.
PACI, partial anterior.
Smaller area in the anterior circulation. Here you get 2 out of those 3 criteria.
Makes sense. LACI, Laiconar.
This one's a bit different. It's about those tiny, deep arteries getting blocked. Your notes mention the specific syndromes, pure motor stroke, pure sensory, ataxic hemiparesis. It's not about the 3 criteria. It's about those specific, almost neat patterns.
So isolated motor sensory signs, often.
Precisely. And finally, POCI, posterior circulation infarct. This involves the back of the brain, the vertebrobasilar system. Think brainstem cerebellum. Your notes mention Wallenberg syndrome, that lateral medullary one.
Ah, yes, dizziness, swallowing problems, the crossed sensory loss.
Exactly. Face one side, body the other. Or Weber's syndrome in the midbrain. Symptoms are often cranial nerve palsies, balance gone haywire, maybe vision issues, but not typically the hemianopia like in anterior strokes. Sometimes bilateral weakness too. Wallenberg's is definitely one to know.
Okay, linking location to symptoms. Very useful. And of course, your notes rightly highlight the FAST campaign.
Can't stress fast enough. Public awareness, but also definitely shows up in exam questions. Face drooping, arm weakness, speech slurred or difficult. Time to call 999 or your local emergency number. Simple, effective. Notes say about 78% predictive value.
And digging a bit deeper, while symptoms overlap a lot, the notes give hints about telling hemorrhagic from ischemic based on likelihood.
Yeah, it's not foolproof from symptoms alone. You absolutely need imaging. But some things make you lean towards a bleed. Your notes flag decreased consciousness up to half of hemorrhagic strokes, plus severe headache, nausea, vomiting, maybe seizures, up to 25%. These are just more common with bleeds. See those? Think bleed first.
Good pointers. Okay, so that's the what. Let's talk why etiology of the cause.
Okay, fundamentally, ischemic is blockage, hemorrhagic is rupture. We said that. For ischemic, the blockage is usually a blood clot, a thrombus forming right there, or an embolus that traveled from somewhere else.
And key sources for those traveling clots, those emboli.
Your notes point straight at atrial fibrillation, AFib. That's a massive one. Irregular heartbeat lets clots form in the heart, then flick off to the brain. Also, infective endocarditis infections on heart valves can send septic emboli. Remember AFib for ischemic stroke.
Definitely. And for hemorrhagic, the rupture causes.
Vessel burst, the biggest culprit listed in your notes. Uncontrolled high blood pressure, hypertension, weakens vessel walls over time. Also, aneurysms, weak spots ballooning out. AVMs, arteriovenous malformations, head trauma, and problems with clotting.
Your notes also smartly separate causes in younger versus older folks.
Yeah, the pattern can shift. In younger patients, your notes mention things like vasculitis, inflammation of blood vessels, inherited clotting disorders, thrombophilia,
Yeah.
SAH, subarachnoid hemorrhage, often from aneurysms, VST, venous sinus thrombosis, and dissection, tears in the artery walls.
Whereas in older patients,
More the classic picture. Atherosclerosis leading to thrombosis right there in the brain arteries, or plaque breaking off and traveling atherothromboembolism. Emboli from AFib become much more common. Spontaneous bleeds linked to hypertension. Sometimes even sharp drops in blood pressure can cause stroke in vulnerable areas. Vasculitis and VST can still happen, but they're relatively more frequent causes in the young.
right, which leads perfectly into managing the risk factors. Modifiable versus non-modifiable. Absolutely core knowledge here.
Couldn't agree more. Modifiable, the ones you or your patient can potentially change. Your notes list the big ones: hypertension again, smoking, diabetes, high cholesterol, obesity, not enough physical activity, drinking too much alcohol, AFib again, and illicit drug use like cocaine. Tackling these is primary prevention.
And the non-modifiable list from your notes.
Age risk just climbs steeply as we get older. Gender overall rates similar, but your notes mention stroke kills more women than breast cancer in the UK, and men tend to have them younger. Family history. Crucially, having had a previous stroke, or TIA, that's the single biggest non-modifiable predictor of another one. And certain underlying conditions, maybe genetic ones.
The notes also break down specific risks for ischemic versus hemorrhagic versus TIA.
Yeah, and you see the logic. AFib pops up strongly under ischemic and TIA. Bleeding disorders like hemophilia or being on blood thinners like warfarin obviously feature under hemorrhagic. Carotid stenosis narrowing in the neck artery is key for ischemic TIA. Plus others mentioned like the combined pill, hypercoagulable states, sickle cell, polycythemia. Knowing these specific links helps.
Okay, let's briefly touch on pathophysiology, the how of the damage. Disrupted blood flow, you said?
Right. Cut off the blood, you cut off oxygen and glucose. Brain cells are hungry and very sensitive. They start to malfunction almost immediately and then die pretty quickly. That's the core issue.
And the way they die differs a bit.
Yeah. Ischemic, clot, stops blood flow. Downstream, cells are starved. That's ischemia, leading to cell death, infarction. Hemorrhagic, vessel ruptures. Blood spills out. That blood itself is toxic to brain tissue. It compresses the surrounding areas, increases pressure inside the skull, so it's direct damage from the blood, plus the effects of pressure and irritation on top of cutting off blood supply further down.
So starvation versus starvation plus toxic compression.
Yeah.
And location determines symptoms.
Always. Motor strip damage. Weakness, Broca's area. Speech production problems, occipital lobe. Vision loss. Straightforward structure function.
Which brings us to a vital clinical question. What else could look like this? Differential diagnosis. Your notes list the main mimic.
Yeah, super important in the heat of the moment. You got to rule these out. Your notes list, TIA, obviously closely related, but management differs slightly in the very acute phase. Migraine with aura can cause weird neurological symptoms. Brain tumors. Brain infections, encephalitis, meningitis, even an abscess. Metabolic chaos, especially low or high blood sugar. Check that finger prick glucose fast. Drug intoxication or withdrawal. And a subdural hematoma, a bleed under the brain's outer layer, can present with gradual onset focal signs. Keep these in mind.
Good list. Okay, zooming out again. Epidemiology. The population impact.
It's huge. Your notes state it's the fourth leading cause of death in the UK. And a massive cause of adult disability. It's not rare, it's a major public health burden.
The stats are stark. 100,000 strokes a year in the UK, over 1.2 million survivors, often with lasting issues.
Exactly. And while, yes, it hits older adults harder, your notes remind us 1 in 4 strokes are in working-age people. It affects everyone. And that stat about killing more women than breast cancer really puts it into perspective for women's health.
Right. And the common lasting effects, weakness, aphasia, vision loss, drive that disability.
Absolutely. They change lives profoundly.
Okay, back to the patient in front of you. Clinical features, assessment approach.
Standard emergency stuff first. ABCDE. Then a focused neuro exam. The common signs we keep mentioning, the fast ones, are key, but your notes broaden it. Facial droop, limb weakness or numbness, speech changes, confusion, dizziness, loss of balance, Sometimes that sudden, severe headache, especially worrisome for a bleed.
And linking back to anatomy, your note specifies cerebral hemisphere strokes cause contralateral signs.
Yes, opposite side. Lesion on the left brain affects the right body and vice versa, usually weakness, sensory loss. Also, homonymous hemianopia, losing the same side of vision in both eyes. And dysphagia, the language issues, often points to the left hemisphere.
Brainstem strokes.
Can be devastating because so much runs through there. Quadriplegia, locked-in syndrome, where you're conscious but almost completely paralyzed except for maybe eye movements. Lacunar strokes, again, those smaller specific deficits, pure motor, pure sensory.
Onset is typically sudden, right? Though the notes say maybe stepwise sometimes.
Mostly sudden, yeah, bam. But sometimes symptoms can fluctuate or progress over minutes to hours, and dysphagia, trouble swallowing, is incredibly common. Your notes say 50–80%. That high number is critical. Immediate aspiration risk means you must do a swallow screen before they have anything by mouth. NBM until proven safe.
Okay, you suspect stroke.
Right.
What next? Investigations and assessment tools. Confirming, typing, finding the cause.
Priority number 1, brain imaging. STAT.CT or MRI. You have to know if it's a bleed or a blockage. Everything hinges on that.
And the notes list reasons for needing that scan within 24 hours. Basically, if treatment might change based on the result.
Pretty much. If you're thinking thrombolysis or early anticoagulation, if they're already on anticoagulants, if they have a bleeding disorder, if their consciousness level is low, GCS-13, if symptoms are worsening or fluctuating, or if there are signs, maybe it's not a simple stroke like papilledema, neck stiffness, fever, that's severe headache.
Okay. And CT angiography, if thrombectomy might be on the cards.
Yep. CTA to see the big vessels in the neck and brain. Check for a blockage that a clot retrieval device could potentially grab.
Beyond the scanner, what bloods and other tests?
Your notes list a good workup. FBC, check platelets, look for polycythemia, sickle cell maybe. ESR if you're thinking giant cell arteritis in an older person with visual symptoms or headache. UNEs, creatinine, LFTs. Glucose critical, rule out hyperglycemia as a mimic. Lipids for risk factors, maybe syphilis screen. Troponin, rule out a heart attack connection. Clotting screen, PT, INR, APTT, absolutely vital before giving thrombolysis or if they're on anticoagulants.
And looking for the source, heart vessels.
Standard 12-lead ECG, looking for AFib mainly, but also other issues. Chest x-ray, maybe an echocardiogram later to look for clots in the heart, valve problems, structural issues. And a carotid duplex ultrasound is key for checking narrowing in the carotid arteries, especially after an anterior circulation TIA or stroke.
Your notes also mention specific assessment tools. Fast for the public. What about for clinicians in the ED?
That's the Rosier score. Recognition of stroke in the emergency room. Your notes say it's recommended by the Royal College of Physicians. High yield for exams.
Rosier. How does that work?
It's a simple scoring system. You actually subtract a point if they had loss of consciousness or a seizure at the start, because those make stroke slightly less likely as the primary event.
Interesting. So LOC or seizure means -1 point.
Right. Then you add 1 point for each of these if they're new and asymmetric. Facial weakness, arm weakness, leg weakness, speech disturbance, or a visual field defect, asymmetry is key.
Okay, so +1 for each asymmetric sign.
Exactly. And your notes state, Rosier score greater than 0 means stroke is likely. Simple threshold, Rosier 0. Think stroke strongly.
Got it. Rosier 0. Right under the core of it, management. Your notes have numbered steps for acute care.
Yeah, a logical flow. Step 1, get them to a specialist, acute stroke unit. ASAP, evidence is clear, this improves outcomes. Step 2, basic homeostasis, oxygen, glucose, blood pressure.
Oxygen only if needed, sats 95%. Keep glucose tight, 411 millimoral. Avoid lows and highs.
And BP. Now, this is important, and your notes highlight the difference. It's managed differently depending on type and treatment plan. For ischemic stroke, if you're aiming for thrombolysis, you need to get the BP down, but keep it below 185, 110. If it's too high, you can't give the clot buster.
Okay, 185, 110 is sufficient for thrombolysis candidates. What about hemorrhagic?
For some hemorrhagic strokes, particularly if presenting early, the goal is often more aggressive lowering, maybe down to 130, 140 systolic, quite rapidly. The idea is to reduce ongoing bleeding, but this is a specialist decision. The key takeaway is BP targets differ.
Crucial difference. Okay, step 6, antiplatelets. Aspirin 300 milligrams daily for suspected TIA or confirmed ischemic.
Yes, but only after imaging has ruled out a bleed. Your notes stress this. Cannot give aspirin if it's hemorrhagic. Critical safety point.
Step 7, thrombolysis. Like alt-Plas for the right ischemic stroke patients.
Within that time window, yes. And again, bleed excluded.
Step 8, anticoagulants. Notes say, Do not start acutely for ischemic stroke usually, and never start until imaging confirms no bleed.
Absolutely. Steps 9 and 10. Practical, but vital. That swallowing screen before any oral intake, essential. And get the patient moving, mobilizing early as soon as safe.
And step 11, thinking about long-term prevention meds.
Right, once things have settled.
Let's zoom in on thrombolysis alteplase in the UK from your notes. What are the absolute deal breakers?
Time window. It's got to be within 4.5 hours of when the symptoms started. That 4.5 hours is a number you just have to know. And repeating again, imaging must rule out hemorrhage first.
And the notes list absolute contraindications, the definite no-go list. Seems important for MCQs.
Definitely. This is stuff you can't ignore. History of any previous brain bleed, ICH, a seizure right when the stroke symptoms began, known brain tumor, suspected subarachnoid hemorrhage, stroke or serious head trauma in the last 3 months, lumbar puncture in the last week, GI bleed in the last 3 weeks, any active bleeding currently, pregnancy, known esophageal varices, and blood pressure that just won't come down below treatment thresholds like 2001/20.
That's a solid list of don'ts, and relative contraindications the maybe but be careful ones.
Yeah, notes mention things like already being on anticoagulants with INR 1.7, known bleeding tendency, active diabetic eye disease with bleeding, suspected clot inside the heart, major surgery or trauma in the last 2 weeks. These need careful weighing of risk versus benefit by the stroke team.
Beyond drugs, what about physically removing the clot? Mechanical thrombectomy? Or surgery?
Thrombectomy is a game changer for certain strokes. Your notes say it's for eligible patients with a confirmed blockage in a large proximal artery, think MCA, ICA, sometimes basilar artery in the posterior circulation.
Eligibility criteria from the notes. Nice 2019.
Key things are how independent they were before the stroke, pre-stroke Rankin score 3, and how severe the stroke is now, NIHSS score 5. Time window is generally within 6 hours from onset. If they also fit the 4.5-hour thrombolysis window, they might get IV thrombolysis first or at the same time. Needs imaging confirmation of the blockage, see TAMARA, and assessment of salvageable brain tissue.
So 6 hours for thrombectomy, 4.5 for thrombolysis. Always image first. Your notes also mention decompressive hemicraniectomy.
Yes, that's a big surgery. Considered for patients, often younger ones, with massive strokes, typically in the MCA territory, causing severe brain swelling. Removing part of the skull gives the brain room to swell, potentially saving their life.
Okay, shifting gears to after the acute storm passes. Secondary prevention. What's the go-to based on your notes?
For preventing another ischemic stroke, your notes are clear. Clopidogrel is generally preferred. It's recommended over the combination of aspirin plus modified release dipyridamole, often called a Santon retard.
So Solbaterol first line.
That's the recommendation noted. Aspirin plus dipyridamole is the alternative if clopidogrel isn't suitable, and if both of those are out, maybe MR dipyridamole by itself. Knowing clopidogrel is preferred is a key guideline point.
And carotid endarterectomy. Surgery for neck arteries.
Considered if the stroke or TIA symptoms match the side with a narrowed carotid artery, interior circulation stuff, if the patient isn't already severely disabled, and if the narrowing is significant. Your notes give the classic cutoffs. 70% stenosis by ECST measurement or 50% by NASET measurement. Need to know those percentages, although research is always ongoing.
Right. We've been through the whole journey of care. What about the long view? Prognosis. What do the notes say about outcomes?
It's a mixed picture, honestly. Survival to discharge is decent, around 85% in the UK, according to the notes, but the disability impact is massive.
Yeah, nearly 2/3 leave hospital disabled to some degree, and 4 out of 10 needing help with daily life. That's huge, a leading cause of long-term disability.
And the risk of it happening again is significant. Your notes say about 1 in 4 survivors have another stroke within 5 years. Plus, ongoing issues like trouble swallowing, incontinence, and that pervasive fatigue are common.
The psychological toll too, depression in a third, anxiety in a fifth, that's really common.
Absolutely. And for working-age survivors, higher unemployment rates. It really impacts every facet of life. Sadly, the notes also mention an inpatient death rate around 24%, showing just how severe the initial event can be for some.
Which flows right into the potential long-term problems, complications. The notes break these down well.
Yeah, it shows stroke's wide reach, neurological issues, ongoing balance problems, movement difficulties, changes in muscle tone, spasticity or floppiness, altered sensation. Pain is common too. Nerve pain, neuropathic, or musculoskeletal pain from the physical changes.
Emotional side effects, depression, anxiety, yeah, but also things like emotionalism, crying or laughing inappropriately, or changes in personality like disinhibition or aggression.
Cognitive problems are a major hurdle. Attention, memory, perception, executive function, that's planning, organizing, problem solving. Big impact on daily life. Speech and communication. Dysphagia affecting language. Dysarthria affecting clarity of speech. Apraxia affecting the motor planning of speech.
Visual problems persist for many, like that hemianopia field loss. Bladder and bowel control issues, incontinence, constipation.
Swallowing issues. Dysphagia can be persistent and really risky, leading to poor nutrition, dehydration, and those dangerous aspiration pneumonias. Sexual dysfunction often gets missed but is important. Just general difficulty with activities of daily living, ADLs, is central.
And other medical complications, too. Blood clots like DVTs or PEs from immobility, pneumonia, pressure sores.
That list really drives home that stroke recovery isn't just about the initial event. It's a long road, often needing a whole team approach.
Wow, okay, we have definitely covered a lot of ground there. From the basic definition and types, through causes, risks, pathophysiology, mimics, the sheer impact, how it looks, investigations, the really critical management steps, acute and long-term prognosis, and that whole range of complications.
And we really tried to stick to the structure of your notes, pulling out what feels most high yield for MSRA revision based on what's there. Getting these core concepts down is absolutely key.
Yeah, hopefully walking through it like this has helped connect some dots and make those key facts, those numbers and guidelines a bit more memorable for you. Definitely review your notes again after this.
Absolutely. And while we focus just on this material, there are always deeper levels interpreting scans, specific rehab techniques, maybe for another time.
For now, if you are prepping for the MSRA and this deep dive helped, don't forget there's more out there. Check out pastthemsra.com and freemsra.com for further revision resources.
Thanks for joining us on this deep dive into stroke.
See you next time.